Thanks a lot, Professor Shore, to be there for this interview. Could you briefly introduce yourself?
My name is Neal Shore. I'm the Medical Director of Carolina Urologic Research Center in Myrtle Beach, South Carolina. I'm a urologist. I have a 15-person clinic where we treat advanced GU oncology patients.
Okay. Yesterday you have a very nice presentation concerning the Garalix, the pooled data of a number of clinical trials. Can you briefly summarize the main results of your presentation, please?
Well, thank you very much. Yes, this was a pooled data analysis of 6 phase 3 trials that were where we evaluated some serum factors as well as progression factors for patients with prostate cancer receiving Degarelix. There were approximately 2,400 patients in our pooled database. Roughly 2/3 received Degarelix, and the other third received LHRH agonists. Half received goserelin, the other half received gluprolide. What we looked at was in these patients at the end of 1 year, this pooled data set, how many of the patients whose PSAs went on to progress. By progression, it was a 50% increase from the nadir. Another way of thinking about that is the development of going from androgen sensitive to castration resistant prostate cancer. And we saw remarkably that there was a statistically significant p-value favoring the Degarelix arm, especially in patients who had higher baseline PSAs. Additionally, we looked at cardiovascular toxicities, and we found a statistically significant difference in cardiovascular events. We think that this translates to an actual difference that we see in overall survival. The patients in the Degarelix arm had an improved overall survival at the end of 1 year at our pooled database versus the patients who received the LHRH agonists. The deaths, approximately 51, were largely all cardiovascular related. Some have asked what would be the biological basis for this. I also demonstrated and showed we see improved reduction in not only alkaline phosphatase, but also FSH. There's some new data that suggests that FSH is clearly present on cardiomyocyte receptors, leukocytes, macrophage, and can have an impact on the endothelium, particularly of cardiovascular plaque.